You're listening to the STA Clinician Podcast, connecting clinicians across healthcare. Okay, and we're live. Hey people, welcome. You're joining us with the guests straight on the screen. Apologies for that. We thought we were live already, so we're going to jump straight into it. If you have joined us, then leave something in the comments. And if you listen to the podcast, then I'm sorry, this was a very abrupt starting to the episode. You are here, you're listening, or either joining us live for the STA Clinician Podcast, formerly the Sports Therapy Association Podcast. And my name is Matt Phillips. If you don't recognize the voice, creator of unchatlive.com. And we are recording this episode live on the Sports Therapy Association YouTube channel and Facebook page. Like I say, if you have joined us live, then we'd love to see comments in the section where you can ask our guests questions directly. This is part 2 of our focus on understanding pain in 2026, in which the topic is going to be predictive processing, which I'm going to define this now, and I'm very worried because with me is Professor Dave Newell and Anna Maria Mazzieri, and this is their bag, and I'm just going to say it. As far as I understand, predictive processing is where your brain guesses what's happening and outputs pain when it predicts danger. But also we're going to be looking at active inference, which is where the brain acts to confirm or update those guesses, which shapes how you move, feel, and interpret sensations. So with me today to discuss that, as I say, Professor Dave Newell, Head of the Centre for Pain and Active Inference Research at Health Sciences University, and also Anna Maria Mazzieri, who is currently a PhD student at Health Sciences University, and also, as many of you will know and recognise, Director of the ST School. Welcome, Professor Dave Newell and Anna Maria Mazzieri.
Thank you for the invite.
Yeah, nice to be here, Matt. Thanks so much.
Really appreciate you joining us. Last week, if you haven't heard it last week, basically, then just we had Dr. Bonnie Lennox-Thompson and Ben Wybrow, who gave us a fantastic introduction to understanding pain in 2026. Tonight, we're looking at something which I think predictive processing, I don't want to imagine or presume that our audience are aware of that. So I'm very keen just to go over what predictive processing is, and then we can go into active inference. But before we do that, Anna Maria, a lot of people, like I say, know you from the ST School and the Hands-On Hub, and for making Therapy Expo fantastic over the last couple of years, and so on, and the other conference which you put together. But not so many people know you or know that you are currently studying a PhD. So maybe you could tell us a little bit about that and how you met Dave Newell.
Yes. Yes, I applied for the PhD because I seen it advertised and I follow Dave Newell anyway, because if you don't follow him, please do so on Facebook and social media, read some of his papers, because he's one of our brilliant minds. And when I seen that, and I already follow the HSU University because they're very, very progressive in what they're doing. And the PhD title that came out really, what can I say? Really matched my what I was studying at the time and what I was working with, which was the trauma paper with Laura Case and the active inference and so on. And I've been learning about active inference for the last 3 years and virtual reality and so on. So it just came at the right time. I've never expected myself to go for a PhD, but actually I am enjoying it very much indeed. And I urge everybody to maybe rethink about their pathway. So for me also it's not just going for the PhD, it's about collaborating and learning more. When Matt, you said, you do not know much about predictive processing and active inference, we are all in the same boat. This is why we're doing it. We are all learning. This is so very new. We're still all getting our heads around it.
This is very exciting coming from you, because anyone who knows you knows that you've been on the case, working with people with pain and trying to understand pain for, I won't say how many years, just so I'm not giving away your age, but a long time.
Pain and touch. This is a lot, steady on. Pain and touch. This is where for me, viewing touch. I'm not talking about massage or manual therapy. Touch in the broader sense through a different lens within pain, within therapeutic environment and so on.
Fantastic. Okay, looking forward to it. Before we turn to you, Professor Dave Newell, just got a few apologies to make. The crowd have joined us now. They're flocking through the door. I'm so apologies. For example, Sarah Jones here from the ST School as well says, "Oh no, all of my witty comments have been lost." I'm sorry, Sarah. I'm sorry they're not around. I'm getting Glenn Murphy, or Sir Glenn Murphy, so he can say anything he wants. But he's telling me that we're 30 minutes late. Apologies, Glenn. Sorry, we did start.
Italian time, Glenn. Italian time.
Yeah,
You should know
I'm
us.
very sorry. Yeah, we can blame it on Anime Mazzieri. That's fine. And Gary Benson, founder of the STA, is also here joining us. Thank you for being patient, people. Gary says, lots waiting on YouTube but nothing happening. Someone just messaged to say it was okay on Facebook. Okay, so maybe you can drop it in the comments whether we are on YouTube as well. But if I have let down everyone on YouTube, I apologize. There will be a recording, obviously, and I'll make sure it goes up on YouTube. And anybody else is here. Nikki Mansfield is here as well, saying me nothing's on YouTube. Oh man. Okay, well, hopefully you can spread the word and make sure people can join us on the Facebook link. Cecily Hislop as well. Good, the old faithful people have all come through the door and they've found us. Wonderful. Right then, so sorry about the interruption. Professor Dave Newell, first time on the podcast. Pleasure to spend time with you. And yeah, maybe you could tell us a little bit about yourself and how Anne-Marie is getting on.
So yeah, we'll leave Maria to the last. I'll come to that in a moment. Okay. I know. All joking aside, it's very unusual, and it's really great for us to have somebody like Maria who's sort of already come in at 36,000 feet in a way, because she's done a lot of stuff before, she's published before, and so she's got a lot of expertise, a lot of real clinical insight, and also obviously teaching all of this as well and setting it up. So I think we feel mutually lucky, I think, to have her at the center, and we're just going through trying to figure out precisely where we're going to land at the moment. I think we've landed somewhere much more than we were a few weeks ago, which I think we were all sort of flying around like jet fighters in the air, trying to come together around what we wanted to do. But no, I'm really looking forward. Anne-Marie is one of 2 PhDs that we have, or 3 PhDs if you include another one that we've got that's slightly out of pain but still in the center. And we've started to build a real community in the center around this particular area. And I think active inference is, I can talk a bit about that in a moment, but active inference I think is a profoundly sort of paradigm shifting idea, I think. And I've heard quite a few people that I really respect that are out there and written books around this who are sort of calling it a sort of paradigm shift that is almost Darwinian in its impact in some sort of ways. But as with most things, it takes something like 14 years for new stuff to come into research and research mentalities and the public arena, for some academics, it obviously takes about like 40 years for things like that. For me, anyway, it takes me 40 or 50 years for this to sort of land. So, but we're really excited about that, and I don't know whether you want me to go on and just give a quick pre-say of the difference between predictive coding and active inference. It's a bit of a counterintuitive thing. I think you probably just already, taken my whole speech, Matt, because I think that little bit at the beginning there, it's pretty much summed it up. Justice. But I mean, we could unpack it a bit more if that's helpful.
I think that'd be great, particularly because I imagine, I don't want to presume or put words into our listeners' minds or mouths, but I think let's just repeat what predictive processing is in your language, and then maybe after doing that we can compare that to active inference and show any similarities or differences or the relationship between the two. Would that be okay?
Yeah, sure. So this idea that if you look back at those diagrams, that back in the sort of 1600s, I can't quite remember when Descartes was around. The guy putting 1630. Thank you. The diagram of the guy putting his hand in the fire and the wires going up from the hand to the brain, and things have moved on a lot from there, obviously. But I think still, this experience that we have of somebody behind the eyes it feels like somebody's here, looking out, like some sort of pilot, sitting up just behind my frontal lobes, and driving everything and so on. And yet when you look in the brain, there's nobody there. There's you can't see it, you can't record it. There's not like a little me looking at a screen. And it's called the theatre of the mind, which is an interesting way of looking at it. And so there's been a lot of work over decades now, recording brain signals and so on, trying to figure out how what are the mechanisms behind how we perceive. And so predictive processing, what came out of that, but it started like in the 1880s with Helmholtz. Probably started before that with Kant and people like that. And was this idea that you guess what's going on. So it sort of inverted the idea that sensory signals come first and then it all travels up to the brain and then it gets integrated in some sort of way, and magically out of that comes this experience. And so predictive coding was sort of born of that idea, and it essentially is precisely that. So if you think about it, photons don't go into the brain. It's not like your eyes are windows where a light goes in. As we know, all that goes in is clicks and electrical signals, all right, of varying frequencies. And that's true of everything that arrives in the brain. And so, I think one of the things that I try to sort of get the students to understand, and probably don't succeed a lot of the time, is if that is true, if the brain is in this sort of bony, black, silent box, how the hell do you experience what you experience when you open your eyes? Because if that's all that's going on, there's a whole bunch of electrical signals in there. This is an amazing experience I'm just having. How the hell is it doing that? And so if you've got the idea that, you can't actually, behind this barrier, you're behind the barrier of your skin, the brain's behind the barrier of the skull, the system that is you cannot reach out into the world. It doesn't experience the world out there. It can't reach out. It only has this stuff coming in. And so the idea would be is that you have to sort of infer or guess what's going on, and that's the typical side of predictive processing. But you can't just guess randomly. So you're trying to guess what the signals are coming from. So what is causing this thing that's arriving, these signals that arise in my head? But you can't guess randomly. You can't be walking down a street somewhere and see something out the corner of your eye and just randomly guess that it's an elephant, or randomly guess that it's an aircraft or whatever. You need to make an educated guess about what it is. So you have to have experienced the world over some sort of time period in order to build this model of the world that you can then guess against. So it's like, I got a model of the world. It may be good, it may be bad, but it's better than just random guessing. Because if you random guess, a black shape coming down the road is, I don't know, something benign, like, I don't know, fairy dust cloud, and you step out in front of it and it's a bus, you're toast, basically. All right. So you have to guess in some sort of way, that's accurate. So you build a model, and then you use the model to make educated guesses about what sensory information is going on. And then you are either near to what's going on in the real world, or you're a long way from it. And so those things could be no gap between your guess and the sensory information coming in, or a very big gap. And so the way that you learn is that you constantly try to reduce the gap. And as you reduce the gap over more and more experience, your model gets better and better. So you're sort of using your sensory information and what's coming in as a way of making the model better and better and better. And so eventually you end up with relatively good models. And they're different models: visual models, auditory models, higher cognitive models of who I am, what's like to happen in this circumstance, and so on. And they get really, better and better. And so predictive coding is that idea, and that you can, if you get a gap, you can close the gap between the sensory information and the guess that you think it is by changing the model. So you make the model better. You update the model in some sort of way. So that's where predictive processing sort of gets to. But active inference takes another step. And did you want to go into that? I mean, maybe Anna Marie can take it from that point. What's the difference between active inference and predictive coding?
I thought it was you going for the active inference. It's shaky, Dave. I'll never forgive you for that. So
Well, I'll help you out. What do you think? Have a go.
yeah. So, and this is where it gets very interesting, because predictive processing brought us something which was meaningful and gave us a vocabulary and a way to understand behavior, because here we're talking to clinicians, so we need, clinicians. But with active inference, we are also adding the extra element of changing the action of changing the prediction. So what we will be doing, what active inference tells us, is that in order to match that prediction, because active inference comes from the underpinning thought that the brain will, or the system will always want to minimize prediction error, because when there is too much error, the system has to work hard to remove that mismatch, and therefore there is loss of free energy, which the system does not want. So we will always try to minimize the error. In order to minimize the error, we act, and this is the beauty of active inference. It is acting, it's producing, behaving, changing our behavior, our action, in order to minimize that prediction error. That is in health, and if we relate it to pain, that is in pain. So actually, we minimizing a prediction error of pain by predicting pain and actually stopping moving in order to prevent that prediction to be mismatched. That is a way to minimize free energy. It's very unhelpful. It's an unhelpful belief. From the system perspective, it is helpful because you are matching the original prediction. So active inference, and the active inference is the work of Carl Fritzen at the beginning of the 2000s. And it's computational. David, can we call it computational neuroscience? Isn't it? Am I right to think
Yeah,
so?
it's computational neuroscience. But it was actually, I think he started with computational psychiatry, which is
Yes.
where we can talk about that at some point around where it explains that sort of stuff too.
Yes, so it's very mathematical for people that looked into active inference. Is the base is very mathematical based. So it's but the theory, there is a theory where then you can build up the framework. But again, that is not the beginning, and come in, David. But it's not the beginning and the end of all, because what we are trying to what we are personally, especially, I am a little bit afraid that we are swapping a Cartesian dualistic reductionist model for another reductionist model. We have to be very, very careful. So some predictive processing and active inference, often from the theorists themselves and those who operationalize those theories, they're actually operationalized often as very brain-centric, i.e., we are, like Dave said it beautiful, we are our brain. Are we? We are not. You see, and this is, and I resonate very much with one of a paper from Mick Thacker, who was one of the strongest proponents of predictive processing, and Jean Hartigan, I can never pronounce his surname. The paper on the predictive processing theory of pain, where it looks at predictive processing not only as a brain computation, but as a whole body perception, which really suits and fit the embodied cognition that we have been seeing in work like very interesting Bronnie was talking about. Actually, that comes, the sense making that comes from a more embodied, the sense making of our understanding of the world comes also from our somatosensory, so sensory motor system, as well as our experiences. So it's beyond just the brain or just the body. Or
So
okay, let me just do a quick recap for our listeners then,
go for
because
it.
I think basically I'm going to
There's some other
tell
bits
you
how
what conclusions I've got from that, and then listeners can ask questions or say. But so essentially, what we're talking about, because I think the first surprise for listeners might be how old predictive processing is. I mean, when we were talking off air, I think as soon as you say the brain is predicting things, I think a lot of listeners probably think that Moseley and Butler came up with that, and that was the whole idea, came from that, explaining pain, that your brain is looking out for danger, and it's actually not. It goes back to, like you mentioned, it basically goes back to philosophy with Kant and then Wilhelm Wundt and when psychology started. So it goes back a long time, which is interesting, because it probably adds more credibility to it in the sense that it's not. We mentioned it last week there, and you mentioned it as well, Maria. There's this problem of brain-centric and this kind of mereological fallacy, as Mick Thacker said to me on Twitter, I think in 2013 or something, and I was like, oh my God, that blows my mind and makes me think a lot about this idea. It's all from the brain. The brain's looking after the body, and we are the brain. But so predictive processing, that's really cool that we've cleared that up. It's actually very computational. It's based on a lot of mathematics and stuff, so that's great. It's the way we operate. And then also, I think what I'm taking from this is, like you said, it links in with what Bronnie Thompson and Ben Weiber were saying last week, in that with the active inference, suddenly we do have to understand that although it's the brain that's processing this, we have to realize that there's all of this external stimuli going on, that there's this environment, this context that we're living in. So although the brain's kind of like processing stuff, we have to be very aware when we're with our patients and clients that of all the whole sensory input that's all around them that could be adding to what decisions, if you like, this kind of brain is making.
Matt,
is that where we are? Or have I kind of...
active inference is a little bit different than predictive process. It's part of it. Active inference is actually us actively trying to minimize the prediction error. Predictive processing tells us that we predict. Active inference, we actively try to minimize the prediction error because we do not want a big prediction error. And what does that mean in clinical practice or in pain? I predict going out for a walk will give me pain. I will feel pain after a walk for 10 minutes.
So active inference could be for better or for worse. It could be used positively, depending on what the framework is, and that's where the clinician comes into it, hopefully. Or it could be leading to kinesphobia and all that sort of stuff.
Correct.
Fantastic.
Okay, so there are some other things I think that we need to add here, because and that was great, Anna, for putting you on the spot there. I do apologize, but you did a great job. So I think you also have to think about, there's another element. So we've got models. Without models, you can't guess anything. You're just random guessing, all right? Without models, in fact, no living things exist, but that's a sort of deeper story. You have the sensory information coming in. You try to close the error gap between the two. As Anna Marie eloquently said, you can either change the model, or if you act on either your body, which can turn body signals up and down, interoception, or you act on the outside world, you can also close the error. So you can either change the signal coming in to fit what you're guessing, or you can change your guess to fit what's coming in. Yeah, and so that bit about acting then becomes a very interesting thing, because that means then that what the system is doing, and I think it's also useful to think about the brain and cognitive bits of the system as being just particular examples of active inference. So they are cognitive examples of active inference. They are the things that allow us to be outside of our bodies, because they generate language and we can commune with each other, and we can watch body language and so on and so forth. And so that is this enactivism where you've got a system that's already embedded in the larger environment as well. But it's important to understand that there are not just one model. You can actually see the whole entity, the whole agent, as a model of its environment. So the idea is that physical things that are living, they build a model of their niche. They build a model of their world, the thing. So if you've got a spider, tiny spider that lives at the bottom of some vast tree in the Amazon rainforest, it doesn't build a model of the entire rainforest because it doesn't really experience that. I mean, they're very distant types of signals, if you like, that may affect, but it tends to build a local sort of model. And the structure is how long its legs are, what it smells, the hairs on the top of its head, how big its eyes are all parts of the system that are modeling the environment or the niche that it's in. And so it is sort of reflecting in some sort of way the dynamics of its local environment. So it's and it stays in that environment to keep minimizing errors. So as long as it doesn't move outside, something, and the classic one is like a fish will find itself out of the water as being very surprising. So that's a very large error gap. And so fish tend to stay in the water to minimize the error gap. All right. So you can act in order to do that. And the idea becomes this amazing idea called self-evidencing, which is that the model that you build, and these are multiple models at different hierarchies, generally just reflect the sort of things you expect if you were in a particular part of your environment. So what happens is it means that your action constantly makes you act in order to stay in bits of your environment that produce the least surprise.
So you can understand how then chronic pain is such a how we see people suffering with chronic pain in the clinic, how they literally manifest their self-referencing, self-evidence, because they're trying to minimize the error. So they continue doing those things because that gives them the sense of self. The sense of self has to be reinforced, because if you're actually mismatching what the prediction are to the reality of their environment, and then they cannot cope with that. So they have to always maintain the coherence in self-evidencing themselves. And this is where, to me, in activism, it's really speaks, I think, a better language than the biopsychosocial model, because the biopsychosocial model is maybe just as it's operationalized, it's not as Engel meant it to, but can be quite a tripod kind of. It's still divided, and also those are factors, and quite separate factors, the lovely Venn diagram. What with an activism instead is not only you have those factors, but you as a system, as an agent, you're actually change. Your influence are influenced by the environment you are in. So you see things because those things afford you to do things. So, and that's where active inference and activism actually, they work very in active inference, because you act to minimize the prediction error, and you act into your environment. Your environment shapes you, but you shape that environment. Yeah. So and this is this is where the cognition, the thinking, call it, is not all in the brain. So the way you feel your world, your proprioception, the way you feel your internal world, your interoception, your exteroception, your somatosensory and sensory motor, they're all they're not just an expression of the brain, they are integral part of how you perceive and process the world. Because then through that you change, your hormones change, and so that's not have to, cognition does not only happen into the brain.
Yeah, I mean, in some ways you can see that there's cognition all the way down in many ways, because if you think about, if you can imagine, if you've got an entity that's got some networking and it can store a model inside of it, you can imagine that there might be a model of some neurons in the dorsal horn that model their local stretch receptors in the muscles that they're connected to. So they're trying to minimize the error between their guesses of where those muscles should be at any particular time, informed by multiple layers coming down, which are all these predictions coming down, and all of these errors that. So most of the time, so you've got active inference units, if you like, at all scales, all the way from cells, all the way up through to societies. And the beauty of the active inference framework is that it sort of explains all of them by the same mechanism, that you're modeling those sorts of things. So that's important to remember that. And cognition is just a particular example of that sort of thing. We mustn't forget precision. We'll come back to that in a moment. But one of the ways of thinking about how organisms stay in a set of states in their environment that match their model. All right. So fish don't explore what's it like to sit on a rock looking in the pond. All right. They don't go that part. I mean, it's a possible thing they could do, but they don't go into that particular dynamic part of the landscape they could occupy. So they occupy these bits of the niche that their model represents, because if they stay in that part of the niche, then their model is minimizing prediction error and maximizing its own evidence. All right, so that's where self-evidencing comes from. And one of the ways of thinking about that is imagine this big house, right? There's this huge party going on in LA. Not that I've ever been to LA, but I can imagine the parties in big houses.
Could be Exmouth.
Exmouth.
Stick with LA, yeah.
Big parties. So, and you've been to those sorts of things where, it's packed in, it's upstairs, it's downstairs, it's really difficult to get to the drinks, you have to push past people and whatever. So imagine that, there is an agent, an active agent like us, or it could be a bit of the dorsal horn, or it could be the visual cortex, which makes a visual model, or it could be an auditory model. All right. So imagine that as a little entity, a person that can move about. Basically, that entity stays in a space in the room amongst a small number of people that are all yes men. So they're all telling it is right all the time. Okay. And they'll stay in that space. So they act to stay in that space. And there's a lot of jostling going on, so they can be pushed away from that space. And also, the number of people joining that particular group of yes men, sycophants around this particular entity, are changing. So that external bit is, and sometimes somebody really weird will come in, and there'll be a big error gap and whatever, but generally it sort of stays the same. So that person is moving around with that group, trying to stay with that group. So that's this idea that you're self-evidencing yourself and you're acting in order to stay within a part of your niche that represents your model. Now, what you could do is you could, and actually moving out of that across the room to some other strangers over there you've never really talked to is really uncomfortable. So that's a lot of uncertainty, and the systems don't like the uncertainty. They're designed to minimize error all the time. But it could be that, for example, you end up with a bunch of people over here, and you get stuck in a group of people that are telling you really bad things about yourself. All right, and you get used to that as the sort of signals that you should match. So you start to match your model to that information going on, and you get stuck over there. And so, and that could be a chronic pain belief, or a prior that's a threat prior or whatever. You just expect pain or whatever because you're in this group. And so in a way, you can almost see the therapeutic encounter and clinicians' role as finding a way of persuading them to go across the room through this really uncomfortable bit where they're neither in one group or the other, back to somewhere where the model that they are generating is fitting with a much more benign set of circumstances that are minimizing the error. Now, so just good with precision. So outside of the sensory information and the models, and we talked about models all the way down, okay, and all the way up, cognition being just a particular example. You also have this contextual ability, and we'll talk about it cognitively because it's a bit difficult to talk about it in terms of a dorsal horn, all right? But you've got this this very big model of the world, if you like, outside your sensory models, that is about, who you are, what you expect, what you normally do, what this situation normally means. If I'm experiencing this is going to happen next, that sort of stuff. And that gives you a huge context. So, for example, if you're walking through a park in London and it's in the fog, and you get some sensory visual signals that are coming in, it looks like it could look like either a dog or a lion. All right. In other words, it's so noisy, the data, it could fit either a dog part of your model or a lion part of your model. You don't see a lion because you're in London and it's really unlikely that you're going to see a lion. So what happens is you distrust the sensory information and you put much more precision on your models because your models are informed by this wider context. Now, if you're on an African savanna, then you're going to probably see a lion coming through because it's more likely you're a lion there, and also you've got this added danger. So even if it is a dog, it's better to think it's a lion because you're not going to get eaten. So there's that threat bit to it as well. So you can then think of conditions that put people in ill health outside of the ones that just mess the whole system up, so you lose active inference. You can't active inference your way out of jumping off a cliff, for example. So there's going to be stuff that just breaks the system up. But lots of conditions you could then think of as just aberrations in precision. You put precision too much on a model when you should be listening to the signals, or you put precision on the signals when you should be modifying the signals with your models about what is most likely to be going on in the world based on your experience. And actually, Friston has talked about this, and there's been a few papers around this. So you can look at, for example, schizophrenia as being something where you've just got way too much precision on your internal models. So you've got no sensory information correcting that. So you've got delusions and hallucinations and so on and so forth. And autism could be the opposite. So there's too much precision on the sensory information. You've got no central model that's dampening that noise down. So you're experiencing all the noise and all the sensory stuff that becomes overwhelming. Now, in a way, you could see chronic pain as being on that precision spectrum. Okay, so you've got precision around a threat prior. So you can start with acute pain. You've got a good balance between the pain and your models and the sensory information coming in. And as that pain dissipates, your model goes back to the guy around the yes men, where there's lots of little lack of errors and so on, and you're back normal. But if the pain persists, and as Anna Marie was saying, one of the ways of reducing uncertainty around this pain persisting is like, why is this pain here? It's still here. One of the ways of reducing that is because you've got an error gap all the time. I've got pain, and I know that my model should be no pain, but I've got this gap, it won't go away. So one of the ways of closing the error gap, and Anna Marie said this, is to just create a new model, a new prior that says I'm going to be in pain all the time.
We have to fill it in. The brain needs to know. It doesn't like uncertainty. We're going to fill it in, and we fill it in with what we got. And this is why those, different factors, mental health, anxiety traits, lifestyle factors, they all contribute to create, or they are priors, or to create beliefs to minimize the gap.
But as you say, the
inference is so beautiful because it brings everything together.
Yeah. So as you say, the problem then is that you generate pain to fit the model. As the nociception dies away, you're now in a situation where you've got a threat model that says, well, this is going to be generating pain.
Yeah.
And so So you generate pain where there's no damage, and that confirms the model. So the model digs deeper and deeper into this landscape, and you get stuck in this new hole. And the problem with getting out of the hole is that as you climb up the side of the hole, because you have to experience more uncertainty.
Yeah.
So to get from this aberrant model that's generating, you've got to.
We've got some questions. And what I'd love is, we've spent 40 minutes on the theory behind it. I mentioned a little bit of the practical, but what I'd like is, I'm going to take some questions. We've got some amazing questions in here. We've also got the great David Poulter in here as well. So get ready for some questions from David.
Mr. Poulter.
Yeah, he's in here as well. Mr. Poulter.
Mr. Poulter, good evening.
So we're going to look at the questions, but afterwards I'd like, if possible, for the last 15 minutes to look at what the listener, the healthcare MSK clinician, should be doing then in order to affect this active inference and the errors and the priors and all the things we've kind of talked about. Before we do that, we've had some amazing questions in here. Thank you again, people who've jumped from YouTube to here. My apologies that YouTube didn't work tonight. It's not a problem, and it's just technology is getting worse and worse. But anyway, David Poulter, thank you so much for joining us. I'm going to bring these up in order, people, so we get them through. I don't think they've necessarily been answered yet, but David Poulter says, we know that sound and vision can be quickly affected by predictive processing, i.e. 𝐵𝐸 misheard lyrics, the chessboard shadow illusion, but why can't pain be influenced quickly by predictive processing in the same fashion?
So do you want, I'll go for this one first. So thank you for that. It's a great question. So there are, Friston has talked about slow and fast models. So some of the higher cognitive models operate at different temporal, on a different temporal basis. Things like vision, for example, they're very precise models, so they don't have a lot of wiggle room. In our analogy of the party, visual models are operating in a very small room with about 6 people. There's not a lot of wiggle room around there, and it works really fast. So, but things like threat priors are very high-level cognitive models that include, my history. They include what I'm expecting. They include all of this, and those models tend to both form and extinguish much more slowly. And so I think that may be a reason for that.
And also because pain is an emergent phenomenon. So vision and sound, they are some sensations. Pain is a phenomenon which is emergent and coming from multifactorial system-wise, and that's, there is this hierarchy.
That's really good. That's a really good question as well, David, because I think everyone's kind of probably familiar with 𝐵𝐸 back in the day, and now it's all over TikTok and that with misheard lyrics. And you're going to hear this, and you do hear them, and it's incredible. And then when they put the new words up, you hear the new words coming up, and that is explained nicely by predictive processing. Yeah, great question. I'm sure you'll be back, David, with a follow-up to that. In fact, I'll just put here some comments. Brian Huxley, thanks for joining us. Brian has said, he said, yes, it can, as it predicts the perception in the context of the original pain. David is back with, I think it's a question here. If we provide positive environmental input, safety and positive feedback, why does this not positively affect chronic pain via predictive processing and or inference? Is that a similar answer? Is it to do with...
Yeah, well, no, but I think it does. So remember we talked about precision, and precision is dependent on this broader, wider contextual sort of place that the cognitive bit of the system is in. So positive environmental input. So that's why therapeutic alliance is one of the few predictors of outcome in musculoskeletal pain, because it provides a safe environment. In that safe environment, if you imagine the pit that we were talking about, that the chronic pain model is in, to experience uncertainty, you're more likely to have a go at doing that if you're in a really safe environment and you trust people. So therapeutic alliance is really important. So I think it probably does do it, but again, I think as Anna Marie was saying, the multivariable aspect and the n=1 effect of patients' idiosyncratic experiences and models means that it's quite difficult to do. So, and I think that's probably why there's been no success looking at generic inputs to, say, help low back pain or musculoskeletal pain. It's been very difficult to find any clear predictors, that are transferable across different settings and so on. And the reason for that, I think, is because in the end, this is a very n=1 type of thing. And so actually, despite all the research, it still really comes down to the clinician in the spot, in the place where the patient is. And
And they're going to use the word here, placebo, in a very positive way in terms of, well, David, you wrote actually a beautiful paper fairly recent. I think it was last year, contextual factors. So we know no interventions is superior to another for chronic pain. Contextual factors, they affect positively outcomes. So I would say, well, possibly changing the context and the positive environmental input might have an effect. The problem in science that we are not phenotyping and we're not yet as good as not testing, studying contextual effect individually or against, and so I think that's where who does respond better to certain things. So possibly that.
Very good. I like it. Emmy Tester has got a comment here. Emmy Tester says, "Hi, Emmy. How you doing, Emmy?" From the ST Scores. Well, love this. It's connecting different things I've been reading about, like identifying with different groups, changing likelihood of behaviours, and of course the whole FELD and awareness of FELD and Grace, and awareness of challenging habitual patterns. It costs energy to change the pattern. What's the payoff? Very good. Nice comment there, Emmy.
Well, I think the payoff is that if you're lucky, as a clinician, you can. I mean, I think for musculoskeletal pain in particular, but I think the therapeutic encounter is a very richly full of affordances and contextual stuff, and I think in many ways, musculoskeletal professions have seen themselves too much as mechanics in a way, and should actually see themselves as gardeners. In the sense that what you're doing is you're creating a landscape across which you, with trust and safety and empathy, persuade the patient system to move back to where it really should be. So the payoff is that you can arrive them back to a place where their system is in a place where there's minimization of error without having to stick with a very aberrant type of prior.
Because it's all about self-regulation. That links a little bit. And that is where I possibly differ from you, David. I would say no. I don't think that we actually create the landscape. I like here to always refer to my son's talk on the liminal space in health. He's an anthropologist, and in plant science, they talk about this liminal space where there is uncertainty, and when the healer and the person, what they do, they co-create, and I love the word. It's about making sense. It's the co-creation of the new transformative, not going back to pre-disease state, but they co-create together equally this new state. And also the liminal space, and this is what I believe that me as a manual therapist, so that's where touch and the encounter, the therapeutic alliance, we create the liminal space, which the space of in between, of a little bit of uncertainty, of where the prediction error can be safely mismatched because you're safe. We create the safety, and then for them, and this is what for me an activism is, we help them sense making. And this is for me touch by creating a little bit more of a precision within the touch, and for them to feel this is an area of pain, but I'm still intact. Yeah, together with everything else a touch brings. But in general, the therapeutic encounter is where the liminal space takes place, but safely. So that when they go out of it, they both co-created a shared decision making, a new transformative space of the person is new. They are changing their environment in a new way. They're going to change their habit, it's behavior change. Behavior change because they update then eventually their model.
It's very good. It's good. We've got the answers are creating more questions. So I'm going to take a couple more questions. Apologies if I don't get through all of them, but we will get replies to you. So I've got one here from David, who's come back. David Poulter says, does predictive processing preclude the necessity for nociceptive input for pain?
Preclude means includes it or
It's not needed.
Not needed and
Not
necessary.
needed.
I think you touched on that earlier on, didn't you, David?
Yes, it is needed.
Sorry, Dave, when you said that even if there's not a nociceptive input,
we are a
then there's
system.
still threat models and
in chronic pain, we are a system. The system includes pain. If you look, for example, I don't know if you read the paper, the 𝐸𝐵𝐸 and Jean paper on predictive processing for pain, where they talk about embodied selfhood and cognition or coming, the predictions and coming from also from the stimuli, somatosensory, but actually then affects the neurological, the endocrine system. So you cannot really separate. The two. Yes, and I would argue.
Yeah, I think that's right. The other thing to think about is that that I don't know that anybody has a really convincing idea about what pain is yet. Still, some people call it emotion. Some people, call it a stack of errors. Some, is it? Can you have pain without nociception? The other, I don't know. I think you can probably experience much more pain with little nociception. And you can experience lots of nociception and very little pain. So I think the thing to remember is that those two things are not necessarily correlated. But the other thing is that if you've got higher threat priors, these ideas that bending over is dangerous, that I'm always going to have this pain, those higher level cognitive stuff, then because of this hierarchical effect of predictions filtering down and errors coming up, and somewhere around there the errors should get extinguished, those predictions can start to change the number of receptors, for example, in the nerve endings that generate nociceptive pain. So you could just turn the gain up by things that you're thinking or where you are. So in a way, when you turn the gain up, are you getting more nociceptive pain? In other words, pain is not just a bunch of signals coming from some nerves in your body. The pain is an experience generated, created, constructed by a whole bunch of different things, including all your cognitive ideas about whether you should be in pain, whether it's really dangerous, or whether it's not. And so I think, nociceptive signals are in many ways, particularly as you become more nociplastic, which I know some people don't like that term, and I agree to some extent, is that, the nociception is just one of the signals that are coming in amongst many others that then construct the experience of pain.
And I also think that maybe that, if we're referring a little bit to the recent tension between, pain and should the question be, can nociception be driven from a top-down mechanism? Not can pain just be driven from a top-down mechanism? Because actually, in the moment in which we perceive, if we have a threat attention bias, and we're always into this sense of lack of safety, and our allostatic system starts working. Eventually, the allostatic load becomes inflammatory, low-level chronic inflammation. Would that activates nociception? Yes. Is that nociception because of tissue damage? No. So, I think we need also to expand. And actually, I'm okay with the fact to know that chronic pain can be driven by nociception. Doesn't change my approach. Doesn't change the fact that psychosocial factors then manifest into pain.
Yeah.
But
I think,
hopefully, if there is an inflammatory driver, then maybe some pharmacological sometimes marker might help or not.
I mean, one of the ways of looking at this is if you've got multiple signals, multiple systems, from cognitive systems to immunosystems to whatever, in a way, these are all they're all individuals that have hands that are able to turn the volume knobs up or down on the other systems. And so, they're all fiddling with each other's, volume stuff, whether it's down or up, and then out of that comes a sort of overall average that then generate. If it's above a certain amount, then it generates a pain experience. If it's below, or so everything's fiddling with everything else.
And that's where phenotyping. To me, this is where phenotyping. We're finding why let's go back a moment to manual therapy, touch. Why people choose to come to manual therapy, places where they also receive manual therapy. They're already self-selecting. Again, McParley and George Esteves, they did a beautiful paper on touch, synchronicity, active inference, where touch is the active inference because we already predict, we already recognize as something very positive, and it has some physiological and emotional, and therefore we kind of helps us to minimize the prediction error, and that people actually choose to come to us because they already know that they respond better, so that they are more embody, and they understand the world more through the embodiment. That should not be the beginning and the end of all, but maybe those people that they understand better. It's like when we teach, we need to understand how somebody respond better. Why don't we do that with our client? Not everybody will respond to the same approach, and that's why for me, an activism and active inference really speaks to me. It's a model that helps.
Okay, I wish you had another hour to do this, but what I'd like to do now, as we've only got about 5 minutes left, are you both okay? It's 9:08. Are you okay for another kind of 5 minutes?
No, we're good.
Just checking.
Yeah.
I wish we had another hour to do this, but I'd like to spend the next 5 minutes, a little bit longer maybe, on the take homes for. First of all, I think the take home is listen to this episode again and dissect it, because I think it's quite heavy, the information we've given. It's going to take some listening, and that's the joy of this podcast, is you can listen to it over and over again, make some notes and test yourself a little bit. But once people understand what's going on here and the mechanisms of action that we're talking about, how will this affect clinicians in how they treat patients who are in pain? What are some examples maybe of what you think, how they should be tweaking maybe what they're doing already, connecting it to what we'll be talking about with predictive processing and active inference?
I'm going to leave this to Anna Maria, but I'm going to make a very broad statement first of all. I'm not a clinician, so Anna Maria is the person to do this. For me, this new framework should allow people to re-see what they're doing through a different lens. Mm-hmm. All right, and so it's a little bit like a paradigm shift. We saw. Because of Einstein's space-time, we saw, building rockets and flying watches around at high speed through a different lens. We didn't change Newtonian physics, but we saw physics through a different lens in terms of movement and so on. And that, people say, well, that's really, what's the point of doing that? So because it's like, well, now I'm doing the same stuff, but I'm just explaining it in a different way. The thing that I think is most important is when you start to get your head around this very profound framework, it starts to I think, should allow you to start to realize that some of the things that you thought you were doing that were peripheral in your care suddenly become really important. And some of the things that you thought were really important maybe are not as important for everybody in that particular care. So for me, a very broad statement would be the take-home message is thinking about this differently. It really makes you look at what, it should make you look at what system you think you're working with. If you think you're working with a patient in a traditional sense, then this makes you think, well, this isn't. You're working with something quite different here to what you thought you were working with. So I would say that would be my take-home message. Anna.
There's so much.
So in clinic,
First of all,
someone's thinking, what am I going to do differently?
yeah, yes. So no. I know exactly what. First of all, it's just having a different narrative is just not enough, because it's you still could be doing the same things, but having the different is having the mindset shift. Because when you have the mindset shift, your clinical reasoning changes. We, like David said, we are not technician anymore. We are not operationalists. We are there personally. Where my advice on how to introduce an active inference is that the most important outcome is to help our clients in sense making. For me, the sense of self is really important. So the making sense of their pain. Okay, and once they feel safe, because once they make sense of the pain, they can feel safer even into the moment of. And the other thing is, so your treatment, call it hands-on or your encounter, everything is part of creating a space where the challenges, that the prediction error needs to be, where there is the mismatch of the prediction error. And you can be there providing the safe environment. And what you do is actually helping them change action. Without action, there is no active inference. So your touch has always to be as a communication tool in this case, or as a sensory input for the client to then act themselves in order to change their space, their environment, their behavior, because they will feel safe to actually go into the space. So what does that mean? Just put them, you do your therapeutic alliance is the framework. Use manual therapy whichever way you use it, but not to change anything. Is to provide maybe more precision onto a pain-free input or as a symptom modification, in order again to then expose them to that error and feeling safe. So gradually expose them to something, but make sure that they got the sense making sorted out. Yeah, because and we know that from literature that, especially in frozen shoulder, the education, once they understand about the natural history, they feel safer. So that if there is that mismatch or prediction error, they still know that they're safe, so they can breathe safety into that potential, previous that it could have been a fear. So exposed to them, but within a safe, but it has to be coming from them, because you are not doing that. It's active inference, is them acting within their environment. Their self-efficacy, it has to be at the basis of everything. Because in my case, that's one of my PhDs, is the sense of self is sense of body ownership and sense of agency. We don't have those ones, we don't have a coherent sense of self, and without that we lose a coherence within the world. So you just step back, co-create with them, expose them to a different movement, a movement that before might have been a little bit more, but they have to be ready for it.
Okay, this is great. This is going to take some.
I think, yeah.
That's
David,
great.
would you agree?
I'm hoping that in the links we can put in some reading material maybe for people to go over this, and we'll definitely need to continue the conversation once I think people have had a little read and taken on board what the mechanisms of action that are going on here to like you say, just look through a different lens. I think that's a really important message is with this evolution of thought and understanding, we're not, very rarely we saying totally change everything. You know, with all the different jumps in history and the way we've kind of found out that doesn't quite work, we're never really saying stop doing that. Maybe apart from sink plunger on the ITB to try and lift up, that maybe we did stop doing. But apart from that I can think of offhand, we're just, but even then, if that's what the patient wants in their world and they're thinking that's helping them, then you would still get a sink plunger and put them on their thigh and just give them that new kind of exposure and that sensation. That's fine. So there's nothing we don't do. But I think it would be nice to have a
we are
follow-up.
one, Matt. That we are an integrated system. We are not the brain. We are not the body. We are not just our thoughts. There is the BBC actually did a fabulous. In our time, Melvin Bragg in August did a fabulous podcast on Merleau-Ponty on phenomenology and talks about embodiment. Honestly,
We'll put that link in there. You sent it to me,
yeah,
didn't you? We'll make sure that goes in the
it's
show notes.
really, really interesting. Again,
That'd be
talking
great.
about phenomenology and embodiment, that actually we are more than our body and we are more than our brain and our.
That's really cool. And that will link into our subjective and the way we're talking and communication, which obviously we haven't talked about at all, but the questions we're
That
using
is
and the
communication
open questions,
as well. This is what I want people to understand, you know. For some people, they feel better when they talk once they are touched, because as Zoe Parlin and 𝐏𝐳𝐧𝐝𝐻 have said in the beautiful Enceritelli, said, touch tells you are like me. Yeah, we are co-specific. So people already, for those people that come through you, don't force touch on people that don't want touch, obviously.
So
We'll
can
try
I
and
just
include. Go on.
Can I just do so? There's a great book called The Self-Evidencing Agent. It's just come out by a philosopher called Jacob Howie. And if you want to dig into, like me, because I'm a complete geek, and like there's not too many of us around, otherwise the world would be an even worse place than it is. But
Apart from the three on the screen at the moment.
If you're really into, yes, of course. If you're into the profundity of how this might affect things, this is a tour de force. Actually, it's that. So I don't think you can see that, can you? No, you can't. I'll put it in the notes. But it's a great book. If you can get hold of it, if you really want to dig into the profundity of this, get that.
And I think I'll also put a link in there. This isn't just a self thing, but a lot of what we talked about, particularly the links between the philosophy and the psychology and the different models and behaviors and thoughts, are actually in my communication course. I've enjoyed so much listening to this, and it so links in with things like self-actualization, even Plato's cave I was going to bring up when you're mentioning the den, and all sorts of things are covered. There's so many links. It's so nice to hear you say names like Wilhelm Kant and things, and just thinking, wow, these are so applicable. So there will be details on my communication course which kind of links in very nicely to this in the show notes as well, for your benefit, not for my profit, just because it links in really well. Right, we've reached the end. I'm going to have to let these two wonderful geeks go. But I'm feeling very much there needs to be a follow-up once people have had time to digest this. If people do want to follow you and look for some more references on these topics, Dave, for you, obviously we've got the hsu.ac.uk, which is the website for Health Sciences University. So there'll be information on there and links to the health. Normally it's health.sciences.university across social media. And then also for yourself, maybe most active on LinkedIn and Facebook?
Facebook maybe. Yeah, I'm an old dinosaur now on Facebook, but and LinkedIn as well. Yeah.
Fantastic. So we'll make sure they go in the show notes. For you, Anna Maria Mazzieri, it's wonderful for you. It's just at the ST school, isn't it? A lot of the time.
I am a little bit on Facebook. I started LinkedIn again, but as you know, you can reach me always and ask questions, and I will always try to reply. But,
amazing. Fantastic. Good.
Thank you, Marco, for inviting us.
It's been a real privilege. Thank you so much.
Oh, that's so kind of you to say, but
really
it's...
You're a fabulous host, Matt. I always say you're very gracious.
I'm just a reflection of you guys. That's all I do. So I'm really excited. This is week 2. This is so cool. And I believe actually, before we just go, thanks everyone who's joining us. Obviously, this is not a personal conversation. This is all still relevant for the people who are still listening to us. I believe that next week, Dr. Rachel 𝐷ewer-Haggart, you've crossed paths. She says she's crossed paths with you, Dave, when she was at Southampton. You might have to look her up and see, but she's crossed paths with you a couple of times. She is currently at the Medical Sociology and Health Experiences Research Group at the Nuffield Department of Primary Care Health Sciences, University of Oxford, which was down in Southampton for a long time as well, working with primary care. So that's going to be next week. And then the week after, just so I don't forget, we've got Dr. Rachel Zoffness, pain scientist, international speaker, science writer. And she's got a new book coming out, Tell Me Where It Hurts, coming out March 26th, which I've had the joy of pre-reading, and we'll be able to talk about that book in a lot of detail. Which again links in quite a lot with what we've been saying in week 1 and week 2, and I'm sure it will be week 3 as well. Right, that's it. Thank you so much for people who have stayed with us, listening in the comments. I know there's still 4 or 5 there. I'm quickly going through there. Sarah Jones, I think, has summed it up. That's all I'm thinking. I need to listen to this again. So much fantastic information to assimilate. Great chat. Thanks. Okay. It is one of those, but that's the joy of the podcast. And if you are listening to this and you've got more questions, which in theory you should have, I mean, I'll be very surprised if you went, yeah, I understand that. Probably either send me an email. I will go on YouTube. I'll make sure there's a version of this on YouTube. Put some questions in the comments on YouTube.
Comment underneath YouTube. Yeah, subscribe.
Yeah, unfortunately, this hasn't gone onto YouTube at the moment as we speak, but I will be. I'll upload the video to YouTube. Nikki Mansfield said, yes, please, to the reading links. Yeah, Nikki, thank you for staying with us. I hope your head is not feeling half as bad as mine at the moment. Bloody brilliant discussion, says Nikki. Thank the Lord for touchy-feely nerds in the least dodgy way possible. Thank you, Nikki, for that. And Imi Tester also says, fantastic episode. It was a fantastic episode.
Yeah,
right,
Imi does Feldenkrais, so all of this should make very much sense.
Hugely with Feldenkrais. And in fact, Todd Hargrove is just on Substack, if you are on Substack, still knocking them out. I remember his first 2 books, Playing with Movement and that, but Todd Hargrove has released some really nice recent things on Substack to do with these questions of nociception and the sensation versus perception and all these sort of things. I mean, again, it's not something for everyone, but personally, I love the way he puts things and really philosophical as well, which is a bias of mine. But anyway, right, let you lovely people go, and that includes my guest tonight, Professor Dave Newell. Thank you very much, Dave. Really appreciate your time.
Thank you.
And also thank you, Anna Maria Mazzieri. And good luck. I'm sure I'll talk to you very soon, but good luck with your PhD as well. It sounds so interesting.
Thank you.
Until that, everybody, I hope you've taken something away today and you are going to join us for the rest of the journey of understanding pain in 2026. I think this episode, again, like last week, just encapsulate that. Understanding Pain in 2026 is a great title for this. So until then, if you can join us next week, next Tuesday, then do please do that. 8 o'clock. It will be on YouTube, he said, crossing fingers, and Facebook. So we'll see you then. Until then, take care of yourselves and obviously continue taking care of each other. We'll see you again very soon. Bye-bye. You're listening to the STA Clinician Podcast, connecting clinicians across healthcare.